Hello, everyone. Welcome to Botswana COVID-19 webinar session number 17, titled COVID-19 Response Lessons Learned from Europe. My name is Dr. Gontse Tshisimogo. I work for the Ministry of Health and Wellness, and I'll be your moderator for today's session. Today, we are going to have two exciting presentations by three wonderful speakers. The first presentation is going to be on the Belgian experience, and the second one is going to be on COVID-19 in the UK experience from the first wave. This webinar is co-organized by Ministry of Health and Wellness, University of Botswana, Botswana-Harvard Partnership, and Rutgers University. Before I introduce today's speakers, let me take you through the webinar housekeeping rules. Can move the slides. Please mute your microphones. Ask questions using the chat function. A moderator will monitor questions, and some will be answered during the presentation or during the question and answer sessions. The session is going to be recorded and made available after the session, both the full recording and the slides, and they'll be available on their own YouTube. Some of the questions were sent before, and they've been forwarded to the presenters, and we hope they'll be answered during the presentation. In case they are not addressed during the presentation, they're going to be addressed during the question and answer sessions. Now, let me briefly introduce our first speaker, Dr. Mari. The last name is a bit difficult, Dr. Mari Villenfagne. She is an emergency medicine specialist working at St. Perry, a university hospital in Brussels, Belgium. She's been working at the same department since 2002, and she has dealt firsthand with the COVID-19 patients. So Dr. Mari, the stage is yours. You can take over.
Yeah, hello. Indeed, I'm Dr. Mari. I work in Brussels. I was there during the first wave, and I'm still there for the second one. And I'm happy to tell you and to help you if it's possible for the COVID in Botswana.
Yes, you can continue, Dr. Mari.
Do you want to continue with my presentation?
Yes, Dr. Mari, continue with the presentation. Thank you.
So, during the first wave in Belgium, we had more or less 17,600 patients who were hospitalized. In the beginning, we just tested the patients who were hospitalized because we had no test for the less ill patients. It's around 1.5% of the Belgian population. 3/4 of the person who were hospitalized were over 50 years old. The median of them was 71 years old, and 75% patients suffered from at least one of the following comorbidities. It means they had some cardiovascular problems, or hypertension, or diabetes, or chronic pulmonary disease. That was the most comorbidities we find with the patient who were hospitalized. A few of them passed away, 6%. 20% of them were hospitalized in the intensive care units, and the median age reached 66 years old. So it's a little bit less than the patient who were, the other patient who were hospitalized. 60% of them recovered, and a few of them were placed under ECMO, extracorporeal circulation. But with the ECMO, it's quite difficult to put an ECMO during this pandemic because we need lots of people, more nurses to take care of an ECMO. And so in my hospital, we didn't use it very often. We just put it for 4 patients during the first wave. During this wave, we have 2 patients under ECMO. So we know that it exists. We just use it if really the patient is very, very ill. So now it's the second wave in Belgium. I put some graph here. You can see that the beds who were occupied in my hospital in Belgium, that's for whole Belgium. We see exactly the first wave, and then we see that during the second wave, for the moment, you see it's until 3 November. We have lots of patients who were hospitalized, more than during the first wave, the peak. And equal for the intensive care beds, we see that during the first wave, it was more or less at the peak, it was 1,250, and we reached the same level for the moment. So the second wave came quickly and with lots of patients in the hospitalization and in the ward and in the intensive unit. We see here other graph with respiratory or invasive ventilation. During the first wave, it was more or less 1,000 patients at the peak, and now we see that there are less patients with invasive ventilation. And as you see, a few patients under ECMO. At the peak in the first wave, it was 45 patients who were under ECMO, and we see that we reach it also, perhaps because we know how we have to use it. We know which are the patients we can put some ECMO. I'll speak about a patient. He's 76 years old. He lives at home with his whole family. So I mean the children and grandchildren. He was positive 7 days ago with a nasopharyngeal smear test. And because of the positive of the test, we asked him to stay at home in auto-isolation. So he knew what he had to do is stay in one room. If it was possible not to share bathroom, toilet and bedroom. So if it was possible, there was just one room for him. In that house, it was possible, and the whole family lived in the other rooms. A few days after, he becomes more ill with asthenia, with anorexia. He didn't eat anymore. 5 days before the ambulance came in. I came with the ambulance a few days before. So 7 days after the test positive. When I came in his room, the saturation was very, very low at 34% on room air, with a respiratory rate very high at 60, heart rate at 160, and with fever. He had some diabetes and asthma. That's indeed some risk factor, and he was previous smoking. He had a previous smoking history. In the ambulance, I could put him with CPAP, so continuous positive airway pressure, because I had a respirator with me. And we went to the hospital with that. With that, the saturation was until 90-94. So it was really nice with that, with the positive pressure. In the blood test, we saw some white cells, CRP, so the factor of inflammation, infection, who are very high. And since the first wave, we used procalcitonin in our laboratory. We didn't use it before, but during the first wave, it was something we used to know if we had to put some antibiotic for the patient or not. Even if the CRP, we can see that it was very high and that he needs some antibiotic. We tested the D-dimer, and it was really high. With the D-dimer, we can suspect that there is an embolism, pulmonary embolism. So just we'll make a scanner, and we make a scanner with contrast to see if there is an embolism or not. So here you see a few scanner, the scanner of this patient. So you see really all the lungs who are ill. That's always the same patient, the same scanner. And you see all the lungs. With that patient, we knew that the scanner will be horrible because of the saturation. So the radiologist told us crown glass opacities. Indeed, that's really the sign, the signature of COVID. With lung condensation in all lobes. He said, indeed, it was compatible with COVID-19, indeed. And for the radiologist, have to tell us if in which class it is. So class 1, 2, 3, it's probably not a COVID. Class 4, it's like it can be a COVID, and class 5, it's really COVID. There is no other possibility. And then we ask to the scanner, to the radiologist, to tell us also how severe is the damage. It's less than 10%, it's until 50%, or it's more than 50%. Indeed, here with that scanner, the damage is 75%. So that patient in 7 days was very, very ill. And we see with lots of patients that they can stay at home until 7 to 10 days. That's really the point where they are very fragile, and at that moment they need oxygen. Some patient who need oxygen, it's really around 7 to 10 days. With that patient had no evidence of pulmonary embolism. So what do we give to that patient? What was the treatment? Non-invasive ventilation for the beginning. So the first day when I came back with CPAP, then we put him in BPAP with some pressure. And with that, we could reduce the oxygen we gave him. And we have an alternative to the BPAP or the CPAP. It's the nasal high flow. That's easier for the patient, but in Belgium we don't use it for in every hospital. So in Saint-Pierre we use it, but in other university hospital in Brussels, for instance, they don't use it. They just use CPAP or BPAP. But with that, we had to raise the oxygen more and more in the hours after that. So rapidly, we had to intubate in the first day at the hospital. So the day after I came with the ambulance with him, we had to intubate him. And a few hours later, we had to put him on ventral prone position. that could help. And with the ventral position, we could reduce again the oxygen we had to give him. And then we gave him some antibiotics, ceftriaxone, 1 a day. That's easier for the nurses to give antibiotic that we just have to give 1 a day, so they don't have to go especially in the room to give that antibiotic. And dexamethasone, 6 milligram during approximately 10 days. But if he stayed in the intensive unit more, he'll receive it more. Then heparin, we give heparin twice a day if the patient is in intensive unit, or just 1 a day if he's in normal yard. That patient had some noradrenaline to help him. So the prone position, we saw during the first wave that it helped a lot the patients, and most patients who are intubated with intubation are on prone position. We see that it reduces ventilation, perfusion mismatching, it reduces hypoxemia, and we see that we can reduce the oxygen we give to the patient, reduce the shunt, and decrease the pleural pressure gradient between regions of the lung. So we can increase with the prone position the recruitment of dorsal lung units. Normally, you don't put a patient on prone position until for the 3 weeks who will come. We try to change from prone position during 12 hours and then to put him back on the back. With that, it really increased the recruitment, and we see that it can help the patient and really help the oxygen and decrease the oxygen we have to give them. Non-invasive ventilation with BPAP or CPAP, it's beneficial by preventing the no recruitment of the alveoli, and that helped the recruitment of new alveoli. But we have really to be careful with that, because sometimes there is an overdistension of previously well-ventilated alveoli, and we don't want to damage the pulmon more than the lung more than it is. Spontaneously breathing patients in acute hypoxemic respiratory failure can generate high respiratory drives and forceful inspiratory efforts that lead to lung injury too. So we have to see we can leave the patient with spontaneous breathing until a certain point. At that point, we have to give him some non-invasive ventilation, and when we see that even if non-invasive ventilation doesn't go very well, we have to intubate him. We don't have to intubate too late. So sometimes the prone position, we can use it with non-invasive ventilation, so with conscious patients, but in my hospital, we don't use it so much. It's quite more difficult to manage it. What do we give as treatment? Dexamethasone for all patients with more than 7 days of symptoms, and if they need oxygen. So for the moment, we don't give that to patient who goes back home, because there is, we don't see, we are not sure it will help them. We give heparin in wards, so I said it before, twice a day if they are in intensive units. There's heparin as Clexane. And then ceftriaxone if there is a suspicion of bacterial infection. We use procalcitonin, but we can also use CRP, or just if we think there is in bacterial infection. We sometimes use remdesivir, but there is no insufficient data for the moment telling that it will really help. So we don't use it for all of the patients. We try to make a study about it to see if it will help or not. Probably we'll have an answer for the next wave. There are lots of really actual questions. For instance, what we'll do with elderly patients. There are some, during the first wave, we had to leave some elderly patients in the house for them. So we don't leave them at home, but in institutions. Sometimes we leave them there because during the peak it was impossible to have them at the hospital. And for during this wave, what we'll do with that, now they have more equipment in the institutions to keep them. They have more oxygen too, but they can just go to 3 to 5 liters of oxygen, and sometimes it's not sufficient. But we tried to make some guidelines to know which patient will put in the intensive unit, because we know that if they are under intubation in intensive units, they are there for 2, 3, 4 weeks or more, and it needs really to have a benefit for the patient after, because after that the road will be very long for rehabilitation. We can have some stock problems because for the moment, since March, we really use a lot of remifentanil, propofol, and tracreum for the patient in the intensive unit. And for the moment, we have not really stock problem, but we know that it can be there if we use it like during the first wave. So the pharmacy in a hospital is looking everywhere in Europe to see if other stocks can come in the to help our hospital. So we have to think about it as the FFP2. At one moment we had no FFP2 more, and so we began to reuse them, to sterilize them and to reuse them. And for the moment, we reuse all our FFP2 3 or 4 days, and with sterilization. So we have lots of ideas to try to help during this second wave. I'm finished with my presentation. I don't know if you have some question or where we can, James, continue. Thank you.
Thank you, Dr. Mari, for the insightful presentation. But in the interest of time, I would like to call in our second presenters. We will take questions at the end of both our presentations. So let me briefly introduce our next speakers, Dr. Rebecca Ryan and Dr. James Milburn. They're going to take us through the COVID-19 in the UK experiences from the first wave. So Dr. James Milburn is an infectious disease specialist trainee from the UK who first came to Botswana in March, but returned to London to support the COVID-19 response. James has since returned to Gaborone, where he is working with Professor Jarvis as a research fellow with the London School of Hygiene and Tropical Medicine and Botswana-Harvard Partnership. Dr. Rebecca Ryan, she recently completed her internal medicine training in the UK and moved to Botswana last month to work with Dr. Chelsea at Botswana-Harvard Partnership. Rebecca spent a considerable time caring for COVID-19 patients over the last few months, particularly those in intensive care units in London. Both James and Becky have extensive hands-on experience looking after COVID-19 patients, and we look forward to learning from them. Doctors James and Ryan, the floor is yours.
Thank you for the introduction. I'm just going to turn off our camera in the interest of saving our bandwidth, as the internet's been a little slow today. But I hope you can all see the screen. So, as has just been said in the very kind introduction, we're two doctors that had just moved, moved to Botswana a couple of months ago, and we're working in the National Health Service in the UK during the first pandemic. And what we thought we'd talk through today is some of the key milestones in the UK epidemic, and then some of the challenges and some of the lessons learned. And then we thought we'd talk through a complicated case that demonstrates some of the extra pulmonary COVID manifestations that should hopefully go well with the excellent talk on the pulmonary manifestations we just had. And then at the end, there'll be time for questions. So this is the timeline of the UK experience, and you can see that the first case of COVID was diagnosed in the UK on the 29th of January. And soon after this, on the 11th of March, the WHO declared a global pandemic. And at this stage in the UK, there was 150,000 people going to watch horse racing at Cheltenham Festival. And Atletico Madrid beat Liverpool 3-2 in front of 50,000 people in Anfield in the Champions League. 5 days after this, the schools closed. And then lockdown followed on the 23rd of March, at which stage the UK have recorded 703 deaths from COVID-19 and over 15,000 cases. The UK lockdown, it wasn't as strict as here in Botswana. For example, you're allowed to go outside to exercise. Non-essential shops were shut, but you were able to travel freely to other shops without a permit, and the restrictions weren't heavily policed. Boris Johnson, the UK Prime Minister, became unwell shortly after lockdown and was admitted to intensive care for 3 days, but he went on to make a full recovery. These restrictions were gradually relaxed from the 10th of May, but local lockdowns were enforced in certain areas. The 27th of July was actually the lowest death rate we'd had since March, but you can see there's still 685 new cases on that day. So we can see that there's ongoing and consistent community transmission, with infection rates subsequently rising in more areas through August, September and October. And further cities were placed into lockdown, and the country's gone into a second national lockdown today. And going back to the start, there was a steady stream of tests being requested based on people having travelled from China, particularly around Chinese New Year on the 25th of January. Initially, all patients were admitted to a side room pending their swab result. But as the majority of the patients initially were actually quite well, we soon asked most to isolate at home. But challenges arose around this, with some patients who shared living areas being unable to isolate effectively. And when the epidemiological case definition was broadened to mainland China and Southeast Asia, patient volumes were far too great, and this system just wasn't feasible anymore. Therefore, we tried a community testing approach. However, when Italy was added into the countries that required testing, this system again became unmanageable. And only patients, in a similar way to what we heard about Belgium, only patients being admitted to the hospital with suspected COVID were tested, and this was due to the limited testing capacity in the UK at the time. And throughout the entire time, we were seeing these patients in hospital and the community wearing full PPE, like I am there on the left, with the numbers of confirmed cases rising. We were traveling to and from work on the underground with no social distance possible, and the station platform across London often looked something like this. This is a graph showing the number of referrals to a single hospital in West London, where I worked later in the epidemic, and it highlights the significant increase in the number of referrals for SARS-CoV-2 testing with the changes in case definition. And you can see when Italy was added to the case definition, we were getting between 30 and 70 cases referred a day to a single unit in a single hospital, which was entirely unmanageable. And unfortunately, testing remains a problem. This graph shows the number of new cases daily and also the positivity rates of the cases of the test performed. Clearly, we can see the UK has entered a second wave, but if we look at the test positivity rates, where the darker red on the graph demonstrates a greater percentage of positive tests, we can see that in the first peak, over 20% of SARS-CoV-2 tests performed were positive. And this suggests significant underreporting of the true number of COVID cases that were seen in the peak of the epidemic between March and April. During the start of the epidemic, as I say, testing was only limited to those patients with suspected COVID that were being admitted to hospital. And this meant that large amounts of community transmission went unreported. And if you look at the majority of countries that have been successful in controlling the pandemic, they have had much greater testing capacity with lower test positivity rates. And even when we move forward here, community testing has been implemented at this stage and testing capacity as a whole has been significantly expanded. This problem does appear to be continuing, and we can see a gradually darkening line. And this is a headline from the 13th of September suggesting that testing capacity in the UK has already begun to become saturated with the second wave of cases. So PPE became a very political topic, with challenges securing enough PPE for healthcare workers, particularly given the proximity to Brexit. Not opting into this EU scheme, this EU PPE scheme, was not accepted by all as necessarily the most appropriate choice, and perhaps a more political one. And PPE guidance changed from full PPE at the very start to later on surgical masks, gloves and apron for routine patient contact, with higher level PPE for aerosol generating procedures. And at the time, some people were concerned that this reflected shortages in the PPE supply, and this provoked anxiety in an already stressed hospital workforce. And there was significant fallout on non-COVID services. So all elective work was cancelled, staff were redeployed to often unfamiliar areas such as ITU, clinics were cancelled and switched to telephone encounters, cancer treatment, mental health services were stopped or severely restricted. And I wanted to talk a little bit about infection control in hospital, because this obviously was extremely important, with nosocomial transmission of COVID an obvious concern. And this tool was developed in UCLH in London to reduce the risk of hospital-acquired infection, and in particular protect vulnerable patients from acquiring COVID. Choosing to isolate suspected patients would protect other patients and staff from potential transmission. However, the high burden of COVID-19 cases soon overwhelmed the availability of single occupancy rooms in many or virtually all hospitals. And as such, patients were risk stratified based on their clinical syndrome, which was made up of their history, their bloods and their radiology, and also their pre-morbid risk. And vulnerable patients with low clinical suspicion of COVID were triaged to side rooms, and other groups of patients were cohorted when isolation capacity was exceeded. And obviously one clear risk of this was the misclassification of patients as high probability of COVID when they actually didn't have COVID, and then being cohorted together with COVID-19 positive patients. But actually the rates of misclassification were relatively low, although this should be viewed that this was done in a time when the pre-test probability for COVID was very, very high. Now, the public perception of the illness and some of the anxiety it provoked played a role in how we responded as healthcare workers, at least in part due to some politicians that I won't name, who advocated the use of certain unproven therapies like hydroxychloroquine. There were multiple requests from patients or their relatives to receive these medications. And this was quite a challenge, because at the time, the only way to access these medications was to be enrolled in RCTs, such as Recovery or the then named Gilead trial. There was an understandable reluctance amongst patients to come to hospital due to the concern about acquiring COVID, or in some cases feeling like a burden on an already overstretched service. And this meant that patients often presented late with both COVID and non-COVID illnesses, and often their condition was a lot more severe. And family members weren't allowed to visit, and this is one of the hardest things of the pandemic, when the family weren't able to visit their critically unwell relatives. Later on, we allowed family members to visit in the last stages of a patient's life, but it was very challenging breaking bad news over the phone rather than we normally would in person. And one issue that was unexpected and I think unprecedented was problems with our oxygen supply. Unsurprisingly, there was a significant increase in the number of people on CPAP or on wall-mounted or Buzniak CPAP as alternatives. And both of these require very high oxygen flow rates, but wall-mounted CPAP more so. And this placed significant strain on the piped oxygen delivery systems in a number of hospitals. And older oxygen systems can supply about 15,000 litres a minute, with more modern systems being able to deliver more. But when this threshold is exceeded, this can cause a catastrophic failure of the piped oxygen system, not through limitations in the total oxygen supply, but due to a drop in pressure demand, due to a drop in pressure from the increased demand. And there were several hospitals that came close to being able to accept patients due to problems with their oxygen supply. As no work could be done immediately to improve this very stretched oxygen system, other alternative measures had to be introduced. And these included decreasing the target saturations to 92% for COVID patients, a move away from this system here, the Buzniak CPAP system, alongside close monitoring of the number of patients on high flow oxygen CPAP and wall-mounted CPAP to try and avoid pressure failure. And at least in the first wave, this seemed to avoid any major disasters. And I'll now hand over to Dr. Rebecca Ryan to discuss a clinical case.
Okay, thank you, James. So today I'm going to talk about some of the extrapulmonary manifestations of COVID-19. So as we know, most patients with COVID-19 have a predominantly respiratory infection, but a proportion of patients progress to a more severe and systemic disease with multiple organ involvement, particularly in the sickest patients. So today I'm going to present a case of a patient I looked after in the intensive care unit in London for over 60 days straight to illustrate some of these points. And although this is a single case, I looked after dozens of patients with very similar clinical courses. This is a huge area to cover in 10 minutes. So today we're going to cover thrombosis, acute kidney injury, and neurological complications secondary to COVID-19. This patient was a 55-year-old married father of 4 of Jewish ethnicity. He had some of the risk factors that we now know made him at more risk of severe COVID-19, including being male, in a slightly older age bracket, and obese with a BMI of 34. But he is a person that we'd normally describe as reasonably fit and well. James has set the scene for where we were in the UK at the time of this patient's illness. His COVID symptoms started on the 22nd of March, the day before the UK lockdown, and he presented to hospital 10 days later after a rapid deterioration with severe hypoxia and in extremis. His COVID swab was positive and his X-ray showed bilateral consolidation. He was stabilised and admitted to the COVID ward, but he deteriorated over the next 48 hours and was admitted to the intensive care unit for CPAP and supportive management. After 2 days on CPAP, he was visibly tiring. His respiratory rate was rising up to between 50 and 60, and his oxygen saturations were dropping. He was unable to tolerate the removal of his CPAP mask even for a few seconds to drink some water, and could no longer tolerate self-proning. On the morning of the 5th of April, 4 days into his hospital admission, he suddenly cried out in pain. His heart rate went up to 180 beats per minute and his blood pressure rose to over 200 systolic. Clinical examination of his left leg revealed an acutely swollen, discolored leg with absent pulses. Clinically, this appeared to be an acute ischemic limb, but ultrasound examination showed an extensive deep vein thrombosis. He was started on treatment with low molecular weight heparin. This event precipitated a significant decline in his respiratory function, and he required emergency intubation the following day. He was therefore too unstable for further management of his leg at this time. And over the course of the next week, it became clear that the left leg was becoming increasingly compromised and became gangrenous. There were several discussions amongst the teams as to the next best steps and his management. For complex discussions related to COVID-19 patients in our hospital, we adopted a 3 wise men approach to decision-making, where 3 senior doctors discussed all complex clinical and ethical decisions. This was in large part because COVID-19 was so new, with new information coming out about it every day. Ethically, it was also really essential to make sure that decisions were well thought through and well documented. The intensive care team felt that the patient would die without an amputation of his left leg. The surgical team were worried that if they did operate, he was likely to lose a lot of blood and had a high risk of dying on the operating table. Even if the operation was successful, an above-knee amputation would make his rehabilitation challenging. This was also discussed extensively with the family, and ultimately the decision was made to proceed with an operation. Fortunately, there was a period of time when he stabilized enough to perform this amputation, and this occurred on the 27th of April, over 3 weeks later. It was complicated by a 4-litre hemorrhage intraoperatively, requiring 9 blood transfusions. Thromboembolism, both venous and arterial, is a common complication of COVID-19 and is associated with an increased mortality. In studies so far, reported incidence of thromboembolic complications in severe COVID disease may be as high as 45%, in comparison to 15% for critically ill patients due to other causes. Incidence is higher in patients who are not on prophylactic anticoagulation. Raised D-dimer levels are found at admission in up to 46% of patients, and an increasing D-dimer over time is associated with increased mortality. So where possible, blood tests including full blood count, D-dimer and prothrombin time should be monitored closely. Studies are ongoing into the optimum regimens for anticoagulation, but all hospitalized patients with COVID-19 should have a VTE risk assessment and should be given low molecular weight heparin prophylaxis if there's no contraindications. Trials are ongoing into whether patients with severe COVID should be given a higher dose of thromboprophylaxis, and evidence from these trials will guide our future management. In the UK, in our ITU, as it sounds similar to what happened in Belgium, we were giving all of our patients in the ITU an augmented prophylactic dose. In critically unwell patients with COVID, as with this one, a lot of problems can happen at the same time. So after the development of his severe DVT, he became increasingly unstable and 2 days later required intubation and vasopressor support. At the same time, his renal function deteriorated and he had challenging fluid balance requirements and a worsening metabolic acidosis. So the decision was made to start him on renal replacement therapy. He remained on renal replacement therapy for just over a month. And during this time, it was complicated by several episodes of his filter circuit clotting. Acute kidney injury is increasingly recognized as a component of severe COVID infection and has been found to occur in around 30% of hospitalized COVID patients, with a much higher incidence, around 60 to 75% in the intensive care setting. Risk factors for acute kidney injury closely mirror the risk factors for severe COVID. Acute kidney injury tends to occur reasonably late into hospital admission, with a median of 10 to 15 days from the start of symptom onset. It's sometimes easy to forget just how little we knew about this disease at the start of the pandemic. One of the very first papers published about acute kidney injury and COVID from China stated in its title that COVID does not result in acute kidney injury. This was published in March at the same time that cases were rising rapidly in Europe and in the USA. And so our clinical knowledge of COVID increased exponentially. A month later, the same group published a letter to the editor saying that there is indeed a link between COVID-19 and AKI, and further studies have supported this. The cause of acute kidney injury in COVID is almost certainly multifactorial, likely both from the direct effects of the virus on the kidney, as well as indirect effects from the systemic effects of the infection. All patients with COVID-19 should be regularly assessed for acute kidney injury, looking at a change in their baseline creatinine or a drop in their urine output. It's useful to do a urine dipstick on hospital admission, as proteinuria and hematuria tend to be associated with a more severe clinical course. Management of acute kidney injury in COVID is no different from the management of acute kidney injury due to other causes, and involves keeping patients euvolemic, which means treating hypovolemia, stopping nephrotoxic medications, and attempting to find the underlying cause of the acute kidney injury. Remember that lots of patients with COVID-19 will be very hypovolemic on admission due to insensible fluid losses from fever and raised respiratory rate, and sometimes diarrhea and vomiting. So this needs to be corrected. From a neurological perspective, it took a long time for this patient to wake up as his sedation was lightened. Due to limitations on resources during the peak of the pandemic, we were sedating patients using morphine and midazolam instead of propofol and fentanyl, and these can accumulate, particularly in patients with poor renal function. And he was neurologically inappropriate for a prolonged period of time. It took him almost 6 weeks to start waking up after he was first intubated. When he did start to wake up, he was disorientated and hallucinating and combative, and it's likely he was suffering from ITU delirium. 48 days into his admission, he developed new right-sided arm weakness and right-sided facial droop, and a CT head scan showed a new left intracranial bleed. This made his physiotherapy really challenging because he had his left above knee amputation and now a new right-sided neurological deficit. Even after he started to recover, he had a further intracranial event once he was stepped down to the ward. There is growing evidence to suggest a range of neurological complications of COVID-19. Even patients with mild COVID symptoms report neurological symptoms including anosmia, fatigue, headache, and dizziness. In terms of more severe COVID neurological complications, by far the most commonly reported are strokes and delirium or acute confusion. Rarer complications include post-infectious autoimmune complications such as ADEM and Guillain-Barré syndrome, and research is ongoing into the link between COVID and these conditions. Patients also sometimes developed iatrogenic complications. Proning injuries are increasingly reported in COVID patients and include facial pressure ulcers and brachial plexus injuries, which we saw in several of our patients. Our patient was proned and deproned for several days once he was intubated, with 16 hours prone lying on his front and 8 hours supine. And he developed pressure sores on his cheeks and an early signs of eye injury. It's essential that these patients have skin assessments, their pressure areas are cared for, and he had 2 hourly repositioning of the head when they're lying on their fronts. Eye care is also really important. Before proning, eyes should be lubricated with ointment and taped shut. Another concerning feature for this patient was that he developed a VRE bacteremia. Several of our intensive care patients developed infections with multi-resistant organisms, which were really difficult to treat. These frequently occurred in clusters in the same cohorted bays of patients. One issue is that staff were wearing the same PPE to look after multiple patients in a cohorted bay, which may have contributed to the transmission of infection. In COVID, it was also difficult to know who to give antibiotics to. These patients frequently spiked temperatures above 40 degrees for days or weeks at a time, so we found it's really important to be guided by culture results. And now we'll talk about this gentleman's discharge. I'm pleased to tell you that after a really long hospital stay, he survived and was discharged from hospital on day 98 after the onset of his symptoms. His next step is a rehabilitation hospital where he can continue to rebuild his life. So, in summary, extrapulmonary manifestations of COVID-19 are common, particularly in severe disease. They may cause multiple organ dysfunction, often at the same time, and lead to a prolonged hospital inpatient stay. Many of these conditions need really good multidisciplinary team care, including from doctors, nurses, physiotherapists, speech and language therapists, and pharmacists, all working together in really challenging conditions. And it's also important to remember that even in the sickest patients, recovery with a good neurological function and reasonable quality of life is possible. Thank you very much.
Okay, another insightful presentation. There's so much to learn, and both presentations shed light on what is happening in Europe, and I hope you have learned as much as I have. So now let me ask my presenters to address some of the questions sent before the webinar, before I open up the floor for questions. So I think there was about 10 questions that were sent before the webinar. Do you have the questions, or do you want me to read the questions to you? Hello?
We have the questions, yes.
Okay, you can.
Okay. I can. So the first one is: does a patient who tested SARS-CoV-2 positive become completely non-infectious after 10 days of not displaying any symptoms? I think on the whole, the majority of patients are not infectious after 10 days. And certainly for patients with mild to moderate COVID, replication competent virus hasn't been recovered from patients after 10 days following symptom onset. But it has been documented in patients who are with severe COVID and perhaps are immunosuppressed. From them, there has been some reports of the recovery of replication competent virus, but in the vast majority of patients, no, you're not infectious after 10 days of displaying symptoms. If that answers it.
What I can say is that in Belgium, we say that you're infected, you have to auto-isolate during 7 days or more days if you have some symptoms. But we say that indeed for 7 days, you're sure infected, and you can infect the others. And after that, if you have no more symptoms, you can go back to work.
Thank you. You can continue.
So the next question is, how risky, or what is the risk that a pregnant mother who tested positive for COVID-19 can infect the unborn child or a born child whilst they are isolating? So we still don't know much yet about the risks of transmission of COVID to newborns born from mothers who have tested positive for COVID-19. There have definitely been some case reports, but it does not seem to be very common. And we still don't know whether newborns get the virus before delivery, during delivery, or after birth from close contact with an infected person. Most newborns that have tested positive for COVID at birth have recovered, but a few have had severe infection and needed to go to the neonatal ITU. So currently, for women who are pregnant, the advice is to take extra precautions to protect themselves from COVID-19. And prevention is definitely the best way to prevent the women themselves, the mothers, from getting COVID, to reduce their risk of passing it to the newborn. And in terms of the mother transmitting COVID to the newborn, current evidence suggests that that is actually reasonably low, particularly if mothers use precautions. So if a mother is known to have COVID-19, current advice is that they wash their hands every time before they touch their newborn, and that they wear a mask if they're coming into close contact with their newborn, for example, if breastfeeding or providing care. But there's obviously a lot of benefit from mothers coming close to their newborn soon after birth in terms of feeding and in terms of bonding. So that's still very, very important.
Okay, at this time, let me open the floor for questions, comments, additions. You can just unmute unmute yourselves, or you can just raise your hand.
Hello, this is Peter.
There's
Can I ask
one
a question?
question.
Can I ask a question?
Yes, go ahead, Dr. Peter.
All right. Good afternoon. So I also put my question in the chat box. So I understand that in the first wave you used limited PPE, apron, gloves, and mask. So do you have any data on healthcare infection and healthcare workers infection and transmission between one another since that limited measure? And if not, are you continuing doing that in the second wave now, that limits PPE, even if you have more PPE available?
Thanks, Peter. Yeah, so if I'm entirely honest, I think the PPE guidance has slightly changed. I think now there is a face mask as well alongside this, but it's still just a surgical mask, a face covering, gloves, and an apron. There were some trials in the UK looking at sort of seroprevalence studies and also like twice weekly PCRs on a group of healthcare workers as sort of, it was called the SAFER study. I think it was at 2 sites across the UK. And I think they sort of identified about 40 to 50% of healthcare workers acquiring COVID between the period from February to April, depending on where they worked. I think anecdotally, we actually felt that one of the big problems that we were mixing together as healthcare workers without PPE in break rooms, in meetings, in other areas. And I think we felt that a lot of the staff or sort of healthcare acquired COVID was perhaps spread through that. So in this second wave, there's a big emphasis across all the hospitals to maintain social distancing and keep distance from your workers and colleagues as much as you can when out of PPE. I think those are the main ones. But yeah, no, I think the PPE is still the same. Obviously, if there are some situations where you'd wear more. So if you're in a room with people on CPAP or there's any aerosol generating procedures, which there's a clear list of, then you'd wear, FFP3, the full kind of long sleeve gown, 2 pairs of gloves and all that. But for sort of routine patient contact with even known COVID positive patients, it's a surgical mask, face covering, gloves and an apron.
Okay, thank you.
If that one's...
Okay, thank you for that. We have 2 other questions on the chat box from Dr. Mpulukeng and Dr. Tilewa. there's a question on the chat box. It reads, is there anything that can be termed post-COVID syndrome? There are a lot of problems that people who had COVID-19 experienced. Some developed hypertension, diabetes, persistent fatigue, persistent shortness of breath, lower limb cramps. So is anyone willing to take up that one before we go to the next one?
So I think in the UK, it's termed long COVID, which is a name that the patients themselves came up with. And that it definitely seems to be a thing in a subset of patients, and not necessarily patients who were really sick with their initial COVID illness. Some people had reasonably mild first COVID symptoms, and yet weeks or even months later are still feeling intense fatigue, shortness of breath, chest tightness, bouts of dizziness, which currently is not entirely explained. But I know that in the UK, in the hospital that James and I worked in, UCLH, they've set up a dedicated post-COVID clinic, where it's a multidisciplinary team approach with physiotherapists, doctors, speech and language therapists working together to see whether they can put together these patterns of symptoms and then find treatments to help people. It's possibly a related illness to ME, myalgic encephalitis, or encephalomyelitis, or possibly chronic fatigue syndrome. But we know relatively little about both of those conditions as well. So it's an area that we need to do a lot of work on.
Thank you for that. Anyone with any questions from the audience? Or before I close? Okay, in the absence of questions, I think we have come to the end of our session. And let me thank the presenters for the insightful presentations. And okay, I'm not sure when the next webinar is going to be, but you get an invitation through your email. So if you are not part of the emailing list yet, you can email armumakwa@yahoo.com. And also let me thank Rutgers Global Health Institute for making this online meeting possible. And to our three presenters, Dr. James, Dr. Ryan, Dr. Mary, thank you so much for your time. And you, the audience, a big thank you to you also, because there won't be any webinar without the audience. So you are very important. Thank you.